The chair calls Ankit Sanghavi, co-lead of the Texas Primary Care Consortium, to give us an overview regarding the population of the uninsured in Texas and how these individuals access health care. Welcome. Please state your name and who you represent.
Ankit Sanghavi, and co-lead as the Texas Primary Care Consortium. Again, good morning, Mr. Chairman and committee members. Thank you for the opportunity to be with you here today. Before I get started with my presentation on uninsured Texans, I would like to just take a minute to briefly give a background on the Texas Primary Care Consortium. We are a statewide collaborative initiative that is co-led by Texas Medical Home Initiative, led by my colleague, Dr. Sue Bonstein, and Texas Health Institute. That's my organization, and I serve as the executive director for. Our mission is to advance equitable, comprehensive, and more importantly, sustainable primary care for all Texans. Our membership partnership represents a diverse group of stakeholders with organizations representing physicians, nurses, payers, purchasers, employers, academia, and more importantly, patients. Again, honored to be with you here today. To get started with my presentation, I'll go on page 2, slide 3, which has 10-year trends of the uninsured rate, both in the state and for the country. The data is most recent is 2021, and the sources from the U.S. Census Bureau American Community Survey. I wanted to note that data for 2020 is missing because the Bureau didn't release as a result of challenges due to data collection and sharing. Again, this is a part of data or point that we have looked at several times in the last couple of years. So rather than repeating, I just wanted to make two observations for your consideration. Is on a positive, we have seen the rate decline both for the country and for the state over the last 10 years, starting in 2011. But it's important to note that the rate of decline for the country is much faster than for us here in Texas. Over the next few set of slides, my goal is to really focus and hone in on the 2021 uninsured data here in Texas and really put that into perspective to see how this rate really varies by different population groups or demographics. Thank you, ma'am. So to get started, again, I'm on page 2. The slide at the bottom is where we really get to understand the uninsured rate in Texans by age and gender. On the left side is where we have the age-wise breakdown. As obvious and discussed in the previous presentation, we really have the highest concentration in the 19 to 64 years age group, followed by our children, which is 0 to 18 years. A couple of observations, again, here to make is that for the children, the uninsured rate in our state is almost twice the rate of uninsured rate for children across the country. Within the 19 to 64 years age group, it's very important to recognize that really the rate is significantly higher if you were to just focus on 19 to 34 years. Looking at gender-wise distribution, which is the chart on the right side of the slide again, a page 2 slide at the bottom, really not a significant difference, but over the years, this has been a constant trend that male tend to have higher rate of uninsured compared to their female counterparts. Moving on, if we really look at the distribution by race and ethnicity, which is on slide 3, the page on the slide on top, American Indian Alaskan Native population in Texas have, compared to their other racial group or counterparts, have a higher rate, little over 27% of uninsured. Looking at by ethnicity, Hispanics or Texans who identify with a Hispanic origin or ethnical background have about 28% uninsured rate compared to non-Hispanic Texans. Looking at the next data point by income level, again, in part reinforcing some of the discussions we have already had. Not a real significant change, but we see the rate upwards of 25% for Texans with household income. Again, this is looking at household income and sources still the U.S. Census Bureau. Both for household income or families with household income under $25,000 and between $25,000 to $50,000, it still hovers around that 25% or slightly upwards of 25%. And then as the income level goes up, we see a decline. Just another observation to consider that we still see, like for family household income for about 100,000 or more per annum, that rate is still at about 10%. Moving on to the next one. Again, I'm now on page 4 and slide at the top, where we really look at, again, two other groups, which is by education and nationality. I think the one on education, which is on the left, is important to acknowledge, just to observe the positive correlationship between educational attainment and insurance coverage, and it's a positive, so just thought it was important to lift up. By nationality, while there is not a significant difference between Texans or U.S. nationals who are U.S.-born and foreign-born, but Texas residents, but within foreign-born Texas residents who are yet to get their citizenship, that rate actually goes up significantly, 49.25%. Said otherwise, no other population subgroup for everything that I've given a breakdown for has that kind of a rate. And then lastly, I think really looking at the geographic breakdown, which is the map on the slide with the map on page 4, we see this distribution by across the state, again, reinforcing some of the data points I've shared and what we have just heard in the previous presentation. We see the concentration most in the border regions along the U.S.-Mexico border, but I think it's important to note that the trends continue for significant portions of West Texas, going all the way up towards Panhandle and the Texas-Oklahoma border, as well as some pockets in deep East Texas. So that's a lot of data, and slicing it apart, really I wanted to reinforce 3 key primary takeaways that, again, the need is most concentrated in the rural and border regions. If I'm looking at it, it's like almost 40% for Presidio County, just southwest of El Paso, or Cameron County in the valley, having about 35%, and then similar rates, again, in the West Texas Panhandle area. So most concentrated in the border and rural regions of the state and among immigrant population. Second is, like, again, young working age adults and Hispanic Texans have relatively higher uninsured rates than their demographic counterparts. And again, it's important to reinforce the positive correlation between higher educational attainment and employment to insurance coverage. So far, for the presentation I've made, I think I've focused on the uninsured of the 100%. So really comparing it to the rest of the state population. Over the next couple of slides, what I wanted to do, hope to clarify, is to probably take a deeper dive in the uninsured population and really have how we see that come across. So the slide, again, at the bottom on page 5 with key insights gives that breakdown of what makes up the 100% of the uninsured population in our state. So starting with the dark blue, which is the first bar at 13%, is essentially individuals who are uninsured but currently eligible for Medicaid or other programs such as CHIP. Roughly translating, I'm talking about a little over between 600 to 700,000 individuals. Said otherwise, these are eligible yet uninsured. The next group, which is the most significant at 42%, are tax credit eligible. I'll read verbatim. This includes individuals who are not eligible for other coverage such as Medicaid or employer-sponsored insurance and who have incomes over 100% of the federal poverty line. The tax credit eligibility shown here, again, this data is from 2021, accounts for the temporary expansion of subsidy eligibility as outlined in the American Rescue Plan Act of 2021. It also includes legally residing immigrants with incomes below the poverty level who do not qualify for Medicaid because they have lived in the country for less than 5 years. But that 42% is the most significant, I would say, portion of the pie. The next, which is the smallest, is 3%, is marketplace coverage eligible. Said otherwise, these individuals have incomes above the threshold, and they actually are eligible to get a plan or insurance through the marketplace or Obamacare. The remaining 12, the next one, which is orange, 12% employer-offered coverage, is these are folks who are employed or in the workforce, have been offered coverage through their employer, but they choose to not enroll for different reasons, which I hope to provide some insights on in the next couple of slides. The remaining 14% is ineligible due to citizenship. And then the last, which is the gray pie, 15% is Medicaid coverage gap. Said otherwise, it just reinforces the discussion we had in the previous presentation, is that little over about 700,000 individuals that will benefit when we talk about expanding coverage or Medicaid expansion. Moving on to the next page, page 6, again, the idea is here to again uncover why, when we see the different breakdown in the previous slide that I shared, that we have a significant number of Texans, uninsured Texans, who are eligible for some program or credit, but are still not enrolled in an insurance coverage. Really, I'll first focus on data for, science and evidence that's been gathered for the country and probably shed some light here in Texas. I will emphasize that data or information in Texas is still developing. We don't have the robust information. So, but I do know that the trends almost have replication for what we observe at the national level to come into play here in our state. Nationally, data from the National Health Interview Survey analyzed by Kaiser Family Foundation really ranks 70% of uninsured individuals across the country have indicated that coverage is just not affordable, whether they are getting through a public funded program or through their employer, 70%. And the next one is at 26%, the next reason is not eligible for coverage. And it's for a combination of things as it relates to citizenship or eligibility requirements. About 23% of uninsured U.S. Or individuals residing in the country do not need or want insurance coverage. About 20% have suggested sign-up was difficult or confusing, and then about 18% cannot find a plan that meet needs. The most insignificant, but still makes up about 3% is folks who have lost job and are in that transition. Within Texas, I wanted to, again, as I re-emphasized earlier, that the data is still not as robust for what we have at the national level, but I wanted to highlight some information that is being uncovered through research led by Texas 2036, another statewide nonprofit. I think they started the effort about a year ago to engage with uninsured Texans and uncovering the reasons or potential barriers they face in finding coverage. And one of their key findings, which I think is important to share, is there is this perception in the population that insurance is an employment-related benefit rather than a standalone coverage or a policy that we could benefit. So it indicates the need for education and increasing awareness, which reinforces the second point. And some of the data we have discussed is that there is just general lack of awareness or underutilization of current programs and subsidies, and then reinforcing the trends we have seen nationally that it is expensive. So I now want to focus on what are the experiences or healthcare experiences and challenges for the uninsured population. The next two slides, which again on page 6 and the slide at the bottom. This slide and the next slide, I wanted to emphasize or clarify that the data is for the country and not just in Texas. So just want to be taken that into account. But really, the trends we know from other efforts or data that have been collected for the state in the past, that this just reinforces the same trend. First slide is for barriers to healthcare among non-elderly adults by insurance status. And as you can see, for a number of different variables, there is a significant difference, almost in some cases 3 times a burden for the uninsured population in not being able to see a doctor or healthcare professional. When I'm talking about uninsured non-elderly adults in the U.S., about 41% go about not having a usual source of care, which is not having a primary care physician. Compared to if you see at the private or public insurance, it's really about at 10%. So 10%, 40%. These are also the individuals who tend more often than any of the other payer groups is they are postponing care due to cost, and in many cases going without care due to cost, as well as delaying prescriptions or not even getting prescriptions filled. We see similar trends in children, though not at such a high level as the adult counterparts or non-elderly adult counterparts. But again, important to emphasize that about 32.2% of uninsured children across the country have gone without seeing a doctor or healthcare professional in the past year, compared to about 8% for those with public or private insurance. Then the question arises, bringing this to Texas, where do uninsured Texans receive care? And I wish there was one straight answer, but it's really a combination of many different access to care points. And my response here is not meant to be the most exhaustive list, but really emphasize or reinforce some of those care points where they receive, or majority of this population receives care. Primarily, the care is provided by our network of federally qualified health centers. Again, we have 72 of those with about over 660 delivery sites across the state. Emergency departments, rural health clinics, nonprofit community and hospital health and hospital systems, critical access hospitals, county indigent healthcare services, charity clinics. And again, as I said, this list is not exhaustive, but again, makes up for a bulk of where majority of this population receives care. To again summarize my presentation, I will reinforce some of the points, but probably highlight a few other implications that I think it's important for us to take into account is, again, the uninsured population, or Texans, are the ones who are paying more than 40% of their annual healthcare expenses out of pocket, which quickly translates into medical debt. And the rate for medical debt, that is, Texans who have some amount of medical debt, is about 18.8%, so that's 19% to round it up. Within the healthcare system, it is costing us about $4 billion annually, and this has been a constant for a good part of the last decade, primarily covered through 1115 waiver allocations. As a state, I wanted to highlight the data or report that the Texas Alliance for Healthcare released back in 2019, where they projected the value of lost earnings and poor health due to uninsurance in Texas to go up to $179 billion by 2040. So again, I appreciate the opportunity to be here and for the Texas Primary Care Consortium to share this information. And with that, I'm happy to take any questions.
Thank you, my friend. That was a great presentation. Members, are there any questions? The chair recognizes Chairman Frank.
Yeah, I appreciate it. I want to go to page 6, reasons for being uninsured. And again, I think I was kind of expecting a different presentation because of the name of the group, Texas Primary Care Consortium. I thought we were going to focus on primary care as opposed to the uninsured. But I want to talk about the reasons for uninsured. Number one, 70%, 3 times higher than any other number, was it's non-affordable, right? Insurance, unaffordable. Healthcare costs in this country, twice as expensive as the rest of the first world for the same results. And so I'm curious what you think your organization can do to address the cost, not just who pays for it, which is always what we talk about, but the actual cost. Why we're paying literally twice as much for the same drugs in this country. Because that's why, I mean, a lot of people choose not to get health care. It's funny, there's 1 million people in the state that make more than 4 times poverty that choose not to take health care. They pay for it out of cash. There's a lot of people that go to the FAQC, or FACQ, sorry.
FQHC.
Federally Qualified Health, FQHC, sorry. They're getting direct primary care. They're getting great direct primary care, which, again, I thought was what we were going to talk about, is the access to care. But nothing that we've talked about is the cost of health care. I'm curious if you have thoughts as somebody, I guess, who's focused on direct primary care, I suppose.
So first of all, thank you for your question. Encouraged, to say the least, and I would love to talk about primary care. And I think in your questions are some of, I would say, the key aspects of my response back to you. And in doing so, I wanted to share some other data that's not on here. And again, what I'll reinforce is I'm committed on behalf of our team and our consortium to be your resource in this pursuit. But as I said, your question itself points to some of the key aspects. So primary care spending in the state, and we do not have one constant resource where I can say that this is being collected annually, but in part through research or report that HHSC collects, other sources that does exist, again with the all-payer claims database. I hope that this systemic barrier is what we'll be overcoming. But so far, and looking at the last 5 to 10 years, primary care spending in our state is about 5 to 7% of our healthcare expenditure. It makes up for 48%, or around about that number, in terms of utilization. And it's proven that primary care does have an impact on 90% of our health outcomes. So my response to uncover here is when we talk about access or bringing the cost curve down, we really need to emphasize or reinforce primary care-centric solution. It is that low-cost setting. And if I'm looking at any of the data points from state or across the country, a majority of our disease burden here in our state, and I would say applicable across the country, is chronic disease. By background, I'm a trained dentist. And chronic disease really requires a prevention and management approach, and not something that we need to be treating in our emergency departments, which is that high-cost setting. So, Representative Frank, again, as I said, encouraged with your question, and the idea is that if we can create primary care-centric delivery solutions or system design and systematically increase our investment in primary care, we are going to see that cost come down.
Totally agree, but that's where I get a disconnect between your presentation and primary care. The reason we don't have primary care is the insurance model that grossly underpays primary care in favor of specialization, yet it seems to be you're encouraging the model that's actually doing the opposite of what you're talking about, and that's why I would love almost to have a redo at some point and actually talk about primary care instead of just talking about the insurance aspect of it.
I appreciate the question and welcome the opportunity to go into the primary care aspect of this discussion. Again, part of the conversation we were having on uninsured today is that this is access to care. So if our work, if I may summarize as a consortium, really is summarized in 3 buckets of increasing access to care. Having insurance is one part of the solution, but access to care will also need that we have adequate network to care for patients. So having the physician capacity, having the capital infrastructure, that is FQHCs, given again the geographic diversity of our state, Medicaid enrollment, or ensuring better utilization of existing resources, telehealth. But the first bucket is access to care, which, if I have to look at this again with a clinical mindset, that is the most critical need that we have as a state, is to fill or bridge that access to care gap. But really, the other parts of our priorities are to look at how can we promote value-based payments that allows us to grow out of this traditional model of fee-for-service that incentivizes this episodic reactive care delivery and not emphasizing or encouraging, if I may say, a prevention-based holistic approach. And then ultimately, where we would love to, again, see the transition be is that systemic investment or strengthening of primary care and really having healthcare design or system in our state, which is primary care centric. So again, the access to care is a critical challenge, more acute as a problem than the 2 other aspects of our work. And again, our idea here was to just be a resource in uncovering what it might take to bridge that problem.
Okay, thank you.
Thank you, sir.
Thank you, Chairman. Chair recognizes Representative Busey.
Thank you, Mr. Chairman. I had a couple questions. You just touched on this a little bit with Chairman Frank, but kind of getting to some of the point of what he was asking, can you explain how primary care helps address access to care for our uninsured population or for anyone who struggles with access? Can you talk about how we do that, what it does, and what the benefits are?
Thank you again, sir, for your question. And I hope to not be redundant, but I'll probably, again, as I was talking about chronic diseases. So again, when we talk about cardiovascular conditions, diabetes, we require more of a prevention first or disease management approach, which is where primary care allows us to have a low-cost environment to be able to do that proactively and not in the emergency department. So again, if the challenge when we see is cost and poor health outcomes, so if those 2 are the priorities, primary care will allow us to achieve that health outcomes and maintain that as a constant, but do so in a cost-effective way. So I do believe that to fundamentally or systematically address the problem of not just the uninsured population, but those facing challenges with access, primary care has a foundational role. Nationally, the National Academy of Sciences, Engineering, and Medicine just released a report last year that emphasized rebuilding the foundation of the healthcare system in the country by prioritizing or strengthening primary care. So thank you, sir.
Absolutely. And I think my other question, and I think it goes at what Chairman Frank was getting at, you talked about 5 to 7% of cost for healthcare is primary care. Can you elaborate a little bit on kind of the scientific literature, what it says about primary care for insured and uninsured, what it says about what you just hit on, how we can really, hit challenges with our healthcare by emphasizing primary care?
Yes, sir. Again, so I would go back to reinforcing the data points that I said, as I shared in the slides on page 6 and 7, that, when we look at the percentage of uninsured population, both adults or children, who do not have a usual source of primary care. It's significantly higher than anyone else, whether I'm talking public insurance or private insurance. So primary care will serve for caring for the uninsured population, but again, in part, like not having insurance is probably prohibiting them, where they just tend to avoid seeking care and wait for that emergency, or by design, not left with many options but to wait for an emergency, and then they get seen by emergency department, which again is dealing with an acute problem rather than, again, taking that prevention management approach. So in part, it's, again, we need to evolve the way we have designed or have operated as a healthcare system, and kind of, again, go through this reform, which will mean not just strengthening points of access, both from a patient standpoint and a provider standpoint, but also be looking at, we will need to have the environment shift to encourage more, if I may say, capitated or population health approaches and payment that allows physicians, care delivery teams, organizations to not be incentivizing, if I may say, episodic fee-for-service care delivery.
Yeah.
And that's where I think we can systematically design and implement strategies that will allow us to grow that investment of 5 to 7%, and in a way that we can also appreciate the returns.
Tell me about, a little bit, if you can, the past that happened with a child that has primary care versus a child that doesn't have primary care. What does that do to outcomes? What does that do to where we're going, where we want these kids to go?
Yeah, again, I mean, so again, as a dentist, there are two conditions that I think make up for the critical needs of children, not just in the state, but nationally or across the board, is tooth decay and obesity, that we all know is a crisis across the country. Obesity leads to diabetes. So if we are not giving that opportunity for the child to see their dentist, their primary care, again, their pediatrician, to systematically address obesity, that kid is going to be then one of the data points in the diabetic population. And then eventually, if they are going to continue having challenges to access to care, they are the ones who are going to be in the emergency department. If no coverage, that's going to be that uncompensated care. So we have an opportunity to again, proactively address and prevent that kid from growing into an adult with diabetes, being in an emergency department, and potentially even risking their life and still costing us more than what it could have taken to even prevent this in the first place.
I appreciate it. And I think hitting on the outcome of their life and the cost in Texas is important, and why we got to do more here. Thank you, Mr. Chairman.
You bet. The chair recognizes Vice Chair Howard.
Thank you, Mr. Chairman. Just to follow up on that a little bit more, and in response to something that Chairman Frank said a while ago about insurance not being equal to receiving health care delivery systems. I mean, it's obviously you can be insured and not get health care. That's not the only part of it. But that being said, not having insurance is absolutely a barrier to accessing health care, as you've just shown us right here. And just to give an example from what Representative Rose and I work on a lot, which is maternal care and postpartum care, the number one recommendation from the Maternal Morbidity and Mortality Task Force to decrease maternal mortality as well as the morbidity is to extend health care coverage for 12 months postpartum. We can actually save lives by doing that because they would still have access to the primary care provider. That once they get dropped off, they may not have that provider access. And so, I mean, that's a classic example to me of how this actually can work.
Yes, ma'am.
That being said, though, I wanted to go back to your slide number 6, and actually back on 5 as well, looking at the tax credit eligible uninsured. The slide on page 6, I think it's, the sources says it's from 2021. And what I was going to bring up is, and you might expand on this a bit, my understanding from having seen an article a while back here on the fact that we significantly increased the number of Texans who got onto the healthcare subsidized plans because of some changes that were made in terms of allowing something to do with family members who didn't get on their employee. I don't know exactly how it worked, but bottom line is I know Senator Nathan Johnson did some kind of a rate review legislation last time that allowed lower premiums and higher deductibles, and the federal government provided better subsidies. The number I saw in this article was that we enrolled 570,000 new people, and that was a 31% increase. So I would imagine on your graph on page 5 at the bottom that second bar of 42% would hopefully have gone down some.
Again, to be objective, I'll go back and confirm, but probably I'll reinforce that we should expect that change to be objectively evaluated as we look at the 2022 data, which the Census Bureau typically releases in September. So this September, we'll be able to actually be very specific of what that number is. But in principle, and given some of the research I have seen be released nationally, one by Kaiser Family Foundation, which is one of the sources I've cited here, is that I believe you are correct that there is a decrease in the proportion of tax credit eligible within the uninsured population, as well as the 3% that marketplace coverage eligible, which again speaks to the other part of the effort that many states, including Texas and the federal government, have really led with over the good part of the last couple of years.
So
we'll see that be visible in 2022.
Great, that's good. So that's good, some good news. And the idea is, of course, that we really need to approach this with all the different barriers and not just look. I mean, obviously, I'm on record of wanting to expand Medicaid coverage, but there are other ways we can also be addressing this, which apparently we have done some positive thing here to start chipping away at that aspect.
Yes, I again believe I will agree with the notion that we need to continue ensuring that things that have worked, whether it's the last couple of years, in the last 10 years, we build upon that and sustain that rather than reinventing the wheel. But even the discussion just we had prior to my presentation, that 13% is what can actually be wiped out. That blue chart, and again on the same slide, that 13%, which is almost, if I look at that Medicaid coverage gap, 15%, I'm talking about like maybe a little under 100,000 less, but we can make insurance be a reality for about 600,000 Texans if we just do a better job of creating more awareness, making enrollment or continued eligibility be more of a seamless process, low-hanging fruit, low-cost opportunity.
And I was going to defer to my appropriations chair, who's not here right now, but
I want to answer for me.
Okay. Hopefully, we are looking at our budget this go-round at increasing reimbursement rates. And the rate reimbursement is a huge barrier to adequacy of providers.
Yes.
And I know I've heard from multiple physicians who it's just not sustainable at the rates that we're reimbursing right now. And until we can reimburse appropriately, we're not going to be able to get adequate coverage. And that's, again, another part of that whole equation. It's a lot of factors involved here. But anyway.
So again, with due respect, I will agree with your comment. And again, as a consortium and looking at this holistically, not just at insurance or payment, as I said, like within access to care, I would again reemphasize, like think about the 4 strategies as part of like the acute relief. So one is to make sure that Texans to have a fair chance to seek care, and insurance is one way of getting there. But then I believe in one of the earlier discussions, there was reference made to geographical challenges, that there are not enough physicians, and I'll be more than happy to share that data at that granular level at county on what does primary care access in terms of having a physician in each of the counties across the state to share as part of a follow-up. It is a significant challenge, and that is only going to worsen, which speaks to network adequacy, because it's unsustainable, if I may say, at the current rate. And not a data point on here, but about if we see there is national data which has been drilled down or has specificity for Texas, that the percentage of physicians who accept Medicaid is one of the lowest in Texas, and it has really seen that decline over the last few years, if I may, given that we have not had a revision of our reimbursement rates, and nothing else but just to account for cost of living or economic inflation. Even if we adjust for that, is going to be a step in the right direction to bring some hope for sustaining that network we currently have. And I'll reinforce, like I believe HHSC has proposed or included in their request to provide a slight increase, and I think it's a step in that right direction. But again, a point-in-time effort will probably not give us the hope to ensure that it's going to be sustainable. It's something we'll have to think through in the long run.
Thank you.
Chair recognizes Chairman Frank.
Yeah, just to clarify, I'm not anti-insurance. I just because I think it's great to have it. I think people, but if we give somebody insurance, but they don't have access to care, that didn't help. And in some cases in the state, we have people who have access to care and have chosen not to buy an insurance product because they have it handled a different way. That's an acceptable thing to do, and in many cases, it's a much smarter thing to do. And I think just sometimes we focus on that one number as opposed to what access are we actually giving somebody to care. So that's my only, I just want to make sure. I think sometimes we're trying to make sure we're actually looking at what we're trying to accomplish, which I think what we're trying to accomplish in all cases is access to better care. In some cases, insurance is helping with that. In some cases, I think insurance is part of the reason that our country pays twice as much, and 70% of your people say coverage is non-affordable. And that if we're never going to address that, we're just, I think we're on a kind of a crazy train. So, thanks.
Chair I see I haven't done this before. Chair recognizes Representative Wally. Thank you.
Thank you, Madam soon-to-be chair at some point. Yeah. We, in your data, it's very good data, right? Because you have barriers and some examples to barriers. Being foreign-born is one, and maybe the public charge is probably a factor. Folks that are they're here legally, right? They just for whatever reason have decided not to take it for fear of some kind of immigration implications, negative immigration implications, right? So one factor, subset of that group, language,
yes,
is one. But have we ever looked, and maybe Kaiser or one of the other organizations or alliances, or maybe your alliance is looked at this at the consortium, is really how much the state is losing by continuing to be a non-expansion state, right? So Affordable Care Act was passed. It provided these carrots and sticks to get folks to expand the coverage or to close that coverage gap. From the time we had federal lawsuit, went to the Supreme Court. Supreme Court says, hey, you can't, use these sticks on states to coerce them, I guess was the words that were used in the opinion. But we're here now, right? That's been years. Do you have any data that would help inform our decisions as far as, and you have members that are on the Appropriations Committee, and you have the chairman here, and you have former subcommittee chair of Article 2 and Representative Price, and a lot of folks on this committee have experience in this. You have chair of the Human Services Committee. from the time that you that we've passed coverage and that where states were allowed to expand, do you have any data as far as how much we've been leaving on the table at the federal level?
Yes, and again, as part of a follow-up, and if the committee is interested, I will be happy to provide both the national level analysis, state level analysis that looks at things retrospectively and prospectively. But that data is available, and happy to make it available.
Okay. Do you have a general sense of how much the state has?
I would say it's in the billions, and I will fall short of giving the number of the billions just because I don't want to misspeak. And again, as I said, like a response to your question is like retrospectively, what have we lost or left on the table, or what we will potentially lose, and what's the current scenario is. So I don't want to give a number and then tie it into a bucket, but I know it's a number that is in the billions.
Is in the billions.
Billion or with a plural.
Right.
But yeah, I'm happy to provide that and be objective in terms of like providing that national level overview or insights as well as state level overview and insights.
That would be very helpful. Thank you.
Yes, sir.
Members, any other questions? If not, thank you so much for being here.
Thank you, Chairman. Thank you, sir.